Hello, my name is Jared Metzen. I'm an athletic training student at the University of Northern Iowa. Today I'll be discussing the diagnostic procedures of a lateral ankle sprain. We will go over the anatomy, the biomechanics, the presentation of the injury, the assessment process, differential diagnoses, indications for referral, and treatment plans. Let's start with the anatomy of the ankle.
Within the ankle joint there are four bones: the distal end of the tibia, the distal end of the fibula, the calcaneus, and the talus. The lateral prominence at the distal end of the fibula is called the lateral malleolus, and the medial prominence at the distal end of the tibia is called the medial malleolus. The tendons of the peroneals may be potentially involved if the mechanism of injury involves inversion. The peroneal tendons wrap around the lateral malleolus and are held down by a superior peroneal retinaculum and an inferior peroneal retinaculum. There are three ligaments on the lateral side of the ankle: the anterior talofibular ligament, also known as the ATFL, the calcaneofibular ligament, also known as the CFL, and the posterior talofibular ligament, also known as the PTFL. The two most often involved in a lateral ankle sprain are the anterior talofibular ligament and the calcaneofibular ligament.
A lateral ankle sprain occurs due to excessive supination of rear foot from an externally rotated lower leg. The increased supination moment is caused by the position and magnitude of the vertically projected ground reaction force at initial foot contact. If the magnitude of the supination moment exceeds magnitude of the compensatory pronation moment, which is produced by the peroneal muscles and the lateral ligaments, excessive inversion and internal rotation of the rear foot occurs, likely causing injury to the lateral ligaments. The anterior talofibular ligament is the most commonly injured ligament, this one right here, which is sometimes followed by the injury to the CFL, which is also known as the calcaneofibular ligament. There can also be damage to the talocrural joint capsule and the ligamentous staplers of the subtalar joint as well. When assessing the condition of a lateral ankle sprain, the healthcare provider must first pinpoint the exact areas of tenderness and swelling. Tenderness may be hard to localize due to the swelling. That's why an assessment may be best suited after the swelling has subsided. Ecchymosis may be present on the medial side, along the foot here, and also on the lateral side as well. To rule out an Achilles rupture, assess the patient's active range of motion in dorsiflexion and plantar flexion. The squeeze test of the gastrocnemius can also be used to rule out an Achilles rupture, which is performed by simply squeezing the muscle belly of the gastroc and seeing if the foot moves in plantar flexion. The clinician should also check for any bony tenderness on the lateral malleolus, the medial malleolus, the navicular, and the base of the fifth metatarsal. Passive inversion and plantar flexion can be done to reproduce the symptoms of the sprain to allow for further testing. The neurovascular status should also be assessed, which can be done by lightly palpating the dorsalis pedis artery as such, and the posterior tibialis artery as such. As I said earlier, the structures most likely involved are the ATFL, anterior talofibular ligament, and the CFL, the calcaneofibular ligament. Then, progressing to assess strength in dorsiflexion, hold for 3 seconds. Good. Then progressing to plantar flexion, hold for 3 seconds as well. Good. Next, we can go inversion here. Hold for 3 seconds as they go into inversion. 1, 2, 3. Good. And then going into eversion for the next 3 seconds. Go. 1, 2, 3. Good. Motion should be ranked on a scale out of 5, with 0 being no muscle contraction at all, 1 being a trace of contraction, 2 active motion only with gravity eliminated, 3 active moment against gravity but no resistance, 4 active movement against gravity with some resistance, and then 5 a perfectly normal movement against gravity with full resistance. To test the ATFL, the anterior drawer test is performed, which has a sensitivity of 0.86 and a specificity of 0.74. To perform the anterior drawer test, the clinician stabilizes the tibia while grasping the calcaneus with the foot in plantar flexion and draws the foot anteriorly, looking for any laxity. To test the integrity of the CFL and the ATFL, the inversion Taylor tilt test is performed, which also has a sensitivity of 0.51 and a specificity of 0.78. Just like the anterior drawer test, the clinician stabilizes the tibia and grasps the calcaneus. The clinician then moves the foot laterally and medially, looking for any laxity. By using the Ottawa ankle rules, the clinician can rule out a fracture if the patient cannot weight bear on the injured foot for more than 4 steps. The patient should then be asked to walk in a straight line to assess their gait pattern. The clinician should observe for any obvious deficiencies. The next step in the process would be to test the patient's balance on the injured foot. If the patient already has inadequate balance, then this test can be skipped.
A lateral ankle sprain can have many other differential diagnoses. The clinician must consider many different possibilities, such as a tendon rupture of the perineals, possible tendinitis of perineals, dislocation, a fibular fracture, a talus fracture, a calcaneal fracture, a metatarsal fracture, or a subluxation of a tendon. The clinician can rule out a fracture by using the Ottawa ankle rules as stated earlier. Any positive signs from the Ottawa ankle rules would be an indication for referral. If there is a dislocation or a subluxation of a tendon, that would be an indication for referral. If the patient reports any numbness, tingling, or neurovascular compromise, that would also be an indication for referral. A severe lateral ankle sprain where the ligament or ligaments are completely ruptured would be an indication for referral as well.
The next step would be to progress the patient to a jog if they are able to. If so, assess their running level, which should be equivalent to game speed. If the patient isn't able to pass any of these next steps, then the patient may have suffered a lateral ankle sprain. Depending on how many steps that the patient progresses on can be a way to assess if the patient has a grade 1, 2, or 3 lateral ankle sprain. A grade 1 is a mild sprain, still painful, but minimal tearing. A grade 2 sprain is moderate, painful, with significant tearing of ligaments. A grade 3 is severe sprain, maybe not as painful, but there are complete ruptures of the ligaments. The treatment plan can vary from patient to patient depending on how severe the sprain is. There can be many ways to treat a lateral ankle sprain. Ice is always, but using NSAIDs can help as well. If the patient can't bear any weight on their foot, then a boot or even crutches may be needed. Always modify any strengthening or stretching activity to fit the athlete. Ankle pumps are a great way to stretch out the ligaments and break up scar tissue, moving nice and slowly, just like I said earlier, moving in dorsiflexion and plantar flexion. Stretches should also be incorporated. Starting with a gastroc stretch, the patient should keep their knee straight and lean forward to stretch out the gastroc, foot slanted up. The next stretch can be a soleus stretch, where the patient bends her knee and leans forward on top of their foot there, still slanted, feeling a deeper stretch. Proprioception exercises would be the next stage of the progression. An example would be starting with normal stance, single leg stance on a pad, then single leg stance with eyes closed. Lastly, make sure the patient is wearing a comfortable shoe that doesn't cause any pain. Long-term treatment plans should also be used to prevent more lateral ankle sprains. Cutting and multi-directional agility drills that progress slowly are great for strengthening the ankle joint. The strengthening exercises from the early stages of rehab should now be progressed to a more advanced stage. Lastly, proprioception is always an important factor in strengthening the ankle so that clinician can design proprioceptive exercises better fit for the athlete for the specific sport.